It is my pleasure to be here with Dr. Rami Khayat. We're thrilled that this year there are finally, after many years, brand new ASM guidelines that have come out this year. And they do include therapy that ZOLL Respicardia makes, which is the remedē system or phrenic nerve stimulation as a transvenous phrenic nerve stimulation. And the indication for this is moderate to severe CSA in adult patients. And the contraindication is an active infection. And if you have questions, additional information on the therapy is available out on the website. Um, please feel free to go out there for all the contraindications and clinical data. But tonight, I would very much like to introduce Professor Rami Khayat, who is the Division Chief of Pulmonary Allergy and Critical Care Medicine at Penn State Hershey Health System Sleep Services at the Milton S. Hershey Medical Center, or Penn State, as it's known there in Hershey. And he's been there about 6 months now, I think, right? So we're thrilled to have him here this evening. I know this has been a long labor of love, and thank you very much for coming this evening. You've had a long interest in CSA, and we're thrilled to have you share your thoughts on your work with these new guidelines. Thank you so much.
Thank you very much, Robin, and thank you, Jamie, and appreciate ZOLL supporting this opportunity to get out there and start disseminating the information. So let me kind of jump in. One of the things I like to start anytime any discussion of central sleep apnea with is why it matters. There's been a bit of turbulence in our approach to or thinking of central sleep apnea in the past few years, and I wanted to get out and say that it is still an important disorder that is associated with consequences. Central sleep apnea has been shown to be independently associated with increased mortality in patients with heart failure. As you can see in this study of over 1,000 patients that were followed for a median of 36 months, that central sleep apnea had significantly, maybe twice the odds of dying than patients without sleep apnea depicted in the black. And that's after adjusting to all known predictors of mortality in heart failure patients. Now, that's not to say that we know that treating central sleep apnea improves survival, but we know for sure that central sleep apnea is an independent predictor of mortality. And that's why it matters to be considering treatment of it, amongst other things too, including its symptom burden to our patients. So why guidelines matter, and especially in a topic like central sleep apnea? Guidelines are obviously based on the current research and evidence and an expert input as well. But they also help us standardize our patients' access to care, so we can ensure that every patient is getting, whatever they present to a specialist with central sleep apnea, they're going to receive the same standard of care, the same access to the available therapies, and the same knowledge and disclosures that are relevant to making their decisions. And the consistency in practice is very important too, because that also help us understand the patient's outcomes. Because say we provided treatment A followed by treatment B, all of us did that in a similar way, then we can learn from the patient's experience and with this sequence or cascade of therapies, and we can understand a little more on what the subsequent decision making and what populations with central sleep apnea need in the future, and how we improve their outcomes. So standardization is very important, especially in a disorder that is not extremely common and that has quite a bit of variability in diagnosis and treatment options. So we're hopeful that these guidelines that the American Academy of Sleep Medicine commissioned would be a step towards that. And the background to this is, number one, the last time there was some guidelines for central sleep apnea was in 2012, even though the European Respiratory Society had taken a look at this since then, but they didn't look at all the available therapies. They focused on PAP modalities specifically. Also, there's been new clinical data on adaptive servoventilation, specifically the trial ADVENT-HF that was published, 2024. So that had to be put in context of our view on the impact of ASV on central sleep apnea. Very importantly, the development of phrenic nerve stimulation since the first guidelines and its relatively wide adaptation and acceptance by patients and clinicians, it did not have a place in the previous guidelines. It was not approved at that point. It was in the phase of development, and it was later FDA approved, I think, as you mentioned, Robin, in 2016 or 17, but definitely not in 2012. There was a great deal of interest amongst patients when the Academy surveyed stakeholders, patients, patient advocacy groups, insurers, other professional organizations, and taking a look at standardizing thus far it's been very heterogeneous approach to treating central sleep apnea. So the Academy set up a diverse task force of sleep and central apnea experts, and with strict conflict of interest management and very regimented, standardized approach that I will spend few minutes telling the audience about how that grade approach applies to developing guidelines and specifically these. So let me show you here. So increasingly, this approach, which GRADE stands for Grading of Recommendations, Assessment, Development, and Evaluation, developed by a group of evidence-based experts. This is becoming increasingly the standard for evaluating guidelines and evidence-based approaches to treatment and other clinical decisions. So the process, as described by the group in a recent publication in the British Medical Journal, involves a systematic review of all the available literature. The group of experts will select the population, discuss the intervention, the comparators for the intervention, and I'll detail that in a bit, and then select what are really the important outcomes for treating a patient with a certain disorder. These could be critical outcomes such as mortality, could be really very important outcomes such as patient symptom burden, and other outcomes, disease severity, and things like that. So the group will determine these outcomes and rate their importance to decision making. Then proceed to looking at the available evidence, synthesizing the evidence, reviewing the literature, and deciding what's good quality to put it in, and then critically appraising it, and then summarizing the findings as the grades of evidence ranging from very low, moderate, and high as far as the quality of evidence. But then taking all that and putting it into a clinical decision-making process that's also systematic as well, and it factors in not just the quality of evidence and the outcomes but it also looks at benefits and harms, the certainty of evidence, the values, patient's preference from what we know from patient advocates and what's available in the literature, and then formulating all this into the guidelines and the strength of the recommendation, again, weak or strong, and conditional or conditional, weak or strong, and whether the recommendations are for or against. So it's a very systematic process that's very, very prescriptive. And it took almost 3 years to go through the relatively thin literature, actually, on central sleep apnea to do this in the proper way. Also, quickly, so people know that, because we get asked sometimes, this paper said this, and there's that paper, but the evidence-based medicine remains, continues to have the same principles. A randomized controlled trial is a higher level of evidence than an observational study, obviously. But all the literature, according to this grade approach, can actually be downgraded because of variety of considerations, such as risk of bias, imprecision. For example, risk of bias can emanate from the sample size. It's a randomized controlled trial, but it's a small sample size. So then that decreases the certainty of that trial, and so on, maybe publication bias and other, again, prescriptive considerations that make a certain piece of literature higher or lower quality of evidence beyond whether it's an RCT or not. And then there is the factors that allow you to upgrade something where a trial that showed another layer of evidence, not only showed an impact of an intervention, but also showed a dose response, for instance, allows you to increase the level of evidence. So that's, again, this methodology. And for people who are interested, BMJ has published a series of 5 or 6 articles on this just between 2024, 2025 that are very interesting. So we use this method in developing the guidelines under the supervision of a methodologist who's trained in this approach to make sure that the process remains very pristine and unbiased from the very beginning to the very end. Now I'm going to jump into discussing a little bit of the synthesis of the literature and how we classified central sleep apnea and identified the population. So in this slide, you'll see on the left some of the more current pathophysiologic classification of central sleep apnea based on loop gain and in patients who may have in addition to loop gain, maybe some component of upper airway, arousal threshold. So very interesting, very exciting work is being done in this area. But the short answer is the clinician really does not have any way to use these physiologic traits right now in clinical practice. So we quickly realized that we have to use the existing classification by the ICSD, which, treatment emergent central apnea and heart failure, opioids, idiopathic, central apnea in medical disorders and or due to medication. And we also found that central hypoventilation often is lumped into this as, and you hear people saying hypercapnic central apnea and hypocapnic central apnea. The hypercapnic variety of hypoventilation syndromes with hypercapnia were excluded from these guidelines because they are a different pathophysiology, different clinical setting. In central hypoventilation, patients have decreased ventilation, they're retaining CO2. In most central sleep apnea disorders, there's increased loop gain and increased ventilatory responsiveness and decreased CO2. So it's almost they're opposite polars, and it did not make sense to lump them all together. So as we moved on looking at the literature and trying to design these PICO, which is population interventions, comparators, and outcomes. So we would say, for example, well, let's look at primary central sleep apnea. What are the interventions for it? What are they compared to? And what are outcomes of interest to patients and experts in the field and stakeholders? We started realizing that people use very wide variety of central sleep apnea classifications. So someone would say, I'm using hypopnea, I'm using apneas, I'm using both, I'm using 70% cutoff, I'm using 50% cutoff. So the literature was very heterogeneous here, making it very difficult to feel like you're comparing actually, apples to apples when you're looking at one intervention in one population. And we also noticed that most interventions really did not have RCTs. Many of them were pre and post and observational, and they were often short-term and rarely compared interventions. So you don't really have adequately long randomized controlled trials, say, comparing BiPAP ST to CPAP or CPAP to ASV in a certain well-defined population. So it was, I will say it was a mess to try to sort through things and try to come up with coherent and consistent approach across all these subpopulations of central sleep apnea. And I put here that there's no acceptable outcome for treatment of central sleep apnea because the symptom burden is confusing sometimes. It overlaps with underlying disorders like heart failure. So it's really hard to tease out what's for central apnea and what's for heart failure. And that did carry through in trials. And most of the community now accepts that treating central sleep apnea has not been shown to improve mortality. So we really aren't out there looking for an impact on mortality, really, in any sleep disordered breathing, obstructive or central sleep apnea. So we had to really struggle to find appropriate outcomes to be able to compare these treatments. So starting with the literature, we narrowed down things were rejected. Most of the things that had CSA were referring to cyclosporin and other things. So the actual studies evaluating treatments for central sleep apnea were limited. And we ended up with about 100 articles that looked at treatments. We're not talking about mechanistic studies and all that, but they were comparative treatments. We ended up with limited literature in the field, unfortunately. So I wanted to show you how we approach this. So because of the limited number of studies, we decided that we will look at every population separately, but it makes more sense for us to help our clinician colleagues if we do some lumping and then look at specifics as well. But whenever possible, if we found some treatment modality that looked at different subtypes of central sleep apnea, like primary, heart failure, medical condition, other things, in order to improve the ability to draw conclusions, we put them all in one bucket and started looking at these therapies. So the one bucket was a major PICO, is almost all the central apnea syndromes. And we looked at interventions, which we divided into positive airway pressure interventions, non-PAP, and pharmacological therapy, which we also quickly realized that all the studies with medications were very acute, 1 or 2 nights. You really couldn't draw conclusions that are relevant to standardized guidelines, except for acetazolamide, which had relatively more interest and a little bit more studies. But the non-PAP therapies were oxygen and TPNS, transphrenic nerve stimulation. And positional therapy, we didn't find any trials. And these were the PAP therapies that we found. And the outcomes, again, we considered treating sleepiness, decreasing the AHI, decreasing hypoxia as critical outcomes. And of course, whenever we could find an impact on mortality or hospitalization, we also considered that as critical and very important. But the other things that were perhaps less critical, so a therapy that didn't improve sleepiness and didn't improve AHI, we didn't really look beyond that. But if it did, we also added these other outcomes like daytime function, work performance, walking distance, improved insomnia, sleep continuity, sleep staging, sleep architecture. Whatever we found, we started looking. I'll tell you a little bit about how we evaluated the outcomes. So we had to lump most of these subpopulations in one PICO because of the limited number of studies and patients. And we designated another PICO to high altitude because there was relatively different entity and clinical setting. For example, you don't really require, when you're looking at high altitude, very long-term studies because you're looking at maybe few days that you want your therapy to work. So something like acetazolamide, for example, doesn't have to work for 6 months or a year in this setting. So we were able to probably look at it in a different light. And also, in general, you weren't really going to initiate de novo PAP therapy over 2 or 3 nights of high altitude. And I know some of our audience may say, look, I practice and I practice in California too, where my patients spent half of the year in high altitude. So there is that hybrid, people who spend time longer than few days, but but those at some point become, what you would call sojourners, or they stay for a period of time, and there really weren't really much studies to support that. So most of the high altitude studies were looking at people who acutely went to high altitude, and at that point, non PAP therapies like oxygen, positional therapy, and medications had most of the literature. So let me, pivot a little bit to talk about selection of outcomes, which I think applies to all sleep disordered breathing guidelines. What is relevant? Now, in central sleep apnea, it's a little bit difficult compared to, say, obstructive sleep apnea, because, in some populations, um, patients don't report sleepiness. For example, heart failure patients have fatigue, but they don't necessarily score high on the Epworth sleepiness scale. But we also needed some measure of sleepiness. So we looked at whatever has out there. The American Academy of Sleep Medicine has already compiled most of the tools, the instruments being used for evaluating outcome measures, and had some sense from the literature, not necessarily, the academy did that, but whatever has been published was compiled for us to look at what's considered as a clinically significant threshold. So is 1 point on the Epworth scale or 2? I mean, obviously you like to see 6 or 7, but if you see 2, that's considered in the literature as clinically meaningful, and so on. AHI, more than 50% reduction. We set that parameter because that's what we've seen in a lot of the studies. Central apnea index, because you want a treatment for central apnea to decrease the central events, and so on. So whatever we could find these clinically significant thresholds, we used them. When we didn't find them, we had to develop some consensus on them. And that's how we developed our outcomes, or our list of outcomes. Um, and we ended up also looking at them in the context of the PICO. So for example, for PICO 1 is, as I mentioned, central sleep apnea, all central sleep apnea syndromes, like in heart failure and opioids. So you would look at the disease burden, excessive sleepiness, mortality, hospitalization, all that. We really wanted to look for them in this population. Now in PICO 2 in high altitude, we didn't expect to see an impact on mortality or hospitalization after 4 or 5 days of, ascending into the mountain and such. So we were looking more at functional outcomes as much as possible. And I'm here on the right of the screen, you will find many instruments that were used, but didn't really have known acceptable thresholds. So we had to make some decisions on them. There were no published guidelines, or they weren't really used in the context of central sleep apnea with known clinical significant thresholds. So at this point, we went on, put all that literature in this kind of process, and we went for each PICO. Let's say PICO 1, central sleep apnea for many causes. What's the quality of the evidence? What's the benefit versus harm? How intensive, resource intensive something is? Would a patient want to do this? And we leaned in on as much access to patient representatives and what's known in the literature on that. Then we classified the outcomes as critical and or important. So we expected that a treatment for central sleep apnea really should improve sleepiness, should improve disease severity measures like AHI and CAI. And whenever reported or available, we looked for mortality and hospitalizations. And I will say we didn't find sufficient evidence there, but that was something we looked for. And then what we considered as important is other measures such as fatigue, sleep architecture, and oxygenation parameters and all that. And then we issued the recommendations based on that. And something to also remember, and under this grade methodology, when guidelines come up with something that is a strong recommendation versus something that is conditional, it's really important to pause here and look at the different implications for different groups. So for example, if you see a guideline saying this is strong recommendation, then the clinician, the clinician, should almost all patients should be offered that recommended course of action. It is strongly recommended based on evidence-based approach and evaluation. And adherence to this recommendation could be used as quality criterion or performance indicator even. And, obviously there are medical legal implications to something like that. Now, when something is a conditional recommendation, the clinician should look at it and say, most patients should be offered. It comes under a we suggest. So it is can be offered, it's suggested. However, different choices may be appropriate for different patients. The clinician must help each patient determine if that suggested course of action is the clinically appropriate course of action for them and consistent with what their values and preferences are. And there are different things that apply to patients and policymakers. So it's basically higher level of emphasis and assertion when it's a strong recommendation versus a conditional recommendation, and the different implications, obviously. So let me show you an example of the recommendation. Obviously, I encourage everyone to look at the clinical practice guidelines published on the website of the Journal of Clinical Sleep Medicine. But this is an example of how we presented this. So for patients with primary central apnea, central sleep apnea, central sleep apnea due to heart failure, central sleep apnea due to medical condition or disorder or medication or substance, we found for the treatment of CPAP, we found 11 randomized controlled trials. They were generally, up to 6 months for the most part. There was improvement in disease severity. There was no impact on mortality or hospitalizations. And we found that the potential benefit was small, but there were no adverse effects. And we thought the benefits outweighed the potential harms. So overall, we issued a conditional recommendation for CPAP in the setting of central sleep apnea based on this process. So when you consult the publications, you'll find also a list of how what outcomes were available with every intervention. This may be important for quality projects, for research, but also for your decision making to as advising the patient. So, for example, CPAP, it was a very low certainty of evidence for Epworth Sleepiness Scale. The absolute difference was below the clinically meaningful threshold of 2, was 1.86, with a wide confidence interval, and but was favorable. AHI, it did decrease the AHI. Again, meeting the threshold of 50%. And you can see the other outcomes that we looked at in mortality and hospitalizations, there were no effects. So I will say the mortality was reported in a post hoc analysis. So in patients who adhered and used CPAP and experienced benefit in AHI. So you couldn't really counsel your patient that CPAP has a mortality effect by any stretch. So, and that's also spelled out in the guidelines in the way that why CPAP is and what outcomes it impacted. So, for example, you'll see here the summary for the 3 main PAP modalities. CPAP was recommended. It's effective at reducing AHI, but did not really always reduce central events in everyone. But when it reduced the central events and the patient was responsive, better outcomes were experienced. There was a new recommendation against using BiPAP without a backup rate, and this recommendation was low certainty and conditional. And the idea is BiPAP can actually destabilize the breathing pattern and induce central apnea. So why use BiPAP without backup rate when you can actually use BiPAP with backup rate and ensure that there is no stimulation of pressure support that varies with patient effort and produces reductions in CO2 and can further destabilize central apnea. In fact, in research studies, we use a BiPAP modality to induce central apnea. ASV was back in the guidelines with a very conditional recommendation, and I will talk about this in a little bit too. And here is a summary of all the guidelines in one table. In general, you will see that the intervention and in which conditions it is recommended for. So acetazolamide was studied in central sleep apnea due to heart failure and primary CSA. It's a conditional recommendation. CPAP versus no CPAP, almost the same for CSA, for most modalities, medication, treatment emergent, and due to medical disorder, and also for heart failure. BiPAP without backup rate, BiPAP with backup rate. So you'll also see how the types of central sleep apnea in which it was recommended for. And for the first time, transvenous phrenic nerve stimulation is now part of the guidelines, and it's recommended for primary central sleep apnea and central sleep apnea due to heart failure. In high altitude, two main interventions were recommended: low flow oxygen and acetazolamide. And again, it's conditional. Everything really received conditional recommendation. I want to just tell you a little bit about acetazolamide and oxygen, but then I'll spend a bit of time telling you about the more novel changes that that are new to the guidelines since the previous ones. So for acetazolamide, it is recommended for CSA due to primary CSA, CSA due to heart failure, medications, treatment emergent, medical disorders, as well as high altitude. It's conditional and low certainty. And it is for these in non-high altitude, for that PICO1, all these other lumped CSA ones, there isn't really adequate long-term studies, but and people have variability. I'll be curious to hear from the attendees how often they're using it, and some of my colleagues are more of users than me, but I think it does have a place in the guidelines and shouldn't be ignored. But it is not widely used, and there aren't really very long-term studies for it as much as for the other treatments such as CPAP, ASV, or TPNS. And oxygen is in the guidelines also, and it did in numerous studies, often with small sample size, it impacted Epworth Sleepiness Scale below the clinically significant threshold, but it had an impact on AHI and central apnea, and in some studies, a small increase in LVEF. So it is in the guidelines, but again, it receives a conditional recommendation. Now, the new kind of kid on the block is the TPNS, which is now part of the guideline and is a new tool, new therapy available to our patients. And the guidelines say the American Academy suggests using transvenous phrenic nerve stimulation over no TPNS due to the following etiologies: primary CSA and CSA due to heart failure. And it is a conditional recommendation. Similar to the other things, it's a low certainty of evidence. The remark that the Academy wanted to put is that, okay, TPNS is an invasive procedure. I think it is part of everyone's kind of decision tree that you don't just implant the patient right away. You try to do something else first, but the idea that it is, maybe you want to try something else first, or at least discuss with your patient something else first, seems reasonable. But the guidelines for TPNS are no less than the other ones as far as the level of evidence and the outcomes impacted. And I'll show you a little bit after. I'm going to talk a little bit about what it is like for those who are not familiar with it, and what kind of evidence is out there for it. So it is fully implantable, similar to Inspire, the hypoglossal nerve stimulation. it sits in a pocket, and a stimulation lead is placed in the phrenic vein adjacent to the phrenic nerve to stimulate unilaterally the diaphragm, producing negative natural breathing type stimulation in the diaphragm, which entrains the breathing and allows the patient to ventilate through central sleep apnea. It consists of a pulse generator and a stimulation lead, basically, as the cartoon here depicts. It does have some unique features as far as how it's turned on and off. It's all programmable, so the patient doesn't really have to worry about turning it on or off. You enter in it the patient's normal natural sleep time, and the device will come on during that window only, but only if few other conditions are met, such as the patient is actually reclining and is not moving for a period of time, then the therapy will come on. So it allows the patient to transition into sleep and will come on, and you can set up, different latencies and different ramps and all that, and different thresholds for different positions too. And the therapy will stop when the patient rolls, but then it'll start again at a new threshold that you set for the left or right. So, it has a lot of customizations, if you will, that can help the sync with the patient's lifestyle and behavior. But it is interesting in the sense that it is not volitional. The patient doesn't really start and stop the therapy like with HNS or other things or CPAP. It is something that it comes on and off programmed. So, takes away a little bit of that work. And here is a polysomnography or mostly polygraphy showing a baseline central sleep apnea, as you can appreciate here in the abdominal belt, thoracic belt, and airflow, classic central sleep apnea at baseline. The therapy comes on here on the right side of the screen, and the breathing pattern is all regularized and is stable, and central sleep apnea is fully eliminated. The oxygen desaturations that you see at baseline are also now normalized. So pretty effective for central sleep apnea. I'm going to walk quickly, actually, through the trial that was done and that we used in the guideline development. So the trial, obviously, when you're doing an implantable device, there are some limitations and considerations, but every participant in that trial received the implant, but the implant was turned on for the intervention arm, and the control arm did not have the device turned on till after 6 months. But the follow-up for the therapy went on to 12 and 24 months, actually, and even beyond that for 4 and 5 years now. But the primary outcome was collected at 6 months, and it consisted of reduction in AHI and reduction of central apnea and hypoxia, and other secondary outcomes included sleep architecture and other things. So and I will show you here mostly the long-term follow-up data to just show which was really of interest to us when you looked at the evidence, because we were pleased to see something that went on more than 6 months to at least be able to tell your patient that, well, yes, the benefit of this device will, or this treatment modality will continue. So this is baseline, and the blue, just gonna move my thing here. So the orange is the central apneas, the blue is obstructive apneas, and there's mixed and hypopneas. I'm sorry, the hypopneas are the blue, and these darker blue are the obstructive apneas. Overall, the AHI is reduced, and the suppression of the AHI persists, through the 5 years, and in almost all parameters. Some of the obstructive events or the hypopneas that are maybe obstructive obviously shouldn't be treated, but the reduction is all to below AHI of 10, so it doesn't really, we're bringing our patients into a therapeutic range with the therapy, and this therapy effect will persist for the 5 years of follow-up on these patients. So the persistence of therapy is of significant interest. These are the outcomes that we looked at in the developing the guidelines as far as TPNS. So the excessive sleepiness, there was 3.7 point reduction, significant, more than the clinical significant threshold in the Epworth Sleepiness Scale, AHI, CAI. We were very interested in hypoxia parameters and oxygen desaturation index, cardiovascular disease, and the EF was a small signal, but this study, the trial was for all comers in central sleep apnea, not specifically heart failure patients. So that's as far as the TPNS. As far as the ASV, which I'm sure many in the attendees are very interested in hearing about it, it is back in the guidelines because when we looked at all the evidence, we didn't really see significant harm signal when you put all the ASV trials together. So you're able to counsel your patient in something that ASV as a class of therapy was not associated with increased mortality, but you really have to do very close follow-up, shared decision-making with the patient, disclosure, as we describe in the document. And we really didn't want people to be exposed to all that work involved in it. So we felt that patients or centers that want to take on central sleep apnea and heart failure with reduced ejection fraction should have some experience in this and have access to escalating the therapy options to, for example, to phrenic nerve stimulation. So you want to try to have access to all the therapies that are recommended for central sleep apnea, but also access to the heart failure specialist and perform close follow-ups to make sure the patient is safe. But we lifted the moratorium saying, oh, it's absolutely inappropriate to use it. We're not there. And I can talk to more as questions come in the next minute or two. But I want to show you specifically this particular meta-analysis that we did, putting all the trials that were selected. And this is on top here is the HFrEF and here HFpEF patients. So the HFrEF trials were 4 that met the criteria. And when we really saw no benefit and no harm as far as mortality, when you put the Advent HF study, which used peak flow device with the Serve HF, which used a minute ventilation device, we did not see that. So here I'm going to try to move on quickly because I want to try to allow us couple minutes to wrap up and then to get some questions for Jamie to share with Robin and I and be able to help with that. So to recap, there were significant challenges in developing these guidelines. One of them is that someone's central sleep apnea isn't exactly someone else's central sleep apnea. People are using their own in these trials, their own criteria at times. And some people classify hypopneas into central and obstructive, and some people don't. The trials were small and they were short-term, and not everyone looked at the same outcome. So it made it very difficult to be comparing, therapies to each other, even if they weren't, arms of the same study. We talked about PAP therapy, but sometimes when you're doing PAP therapy trials and patient rejects the treatment based on intolerance of pressure or mask, may not necessarily make sense to keep on running. Look, I'm going to move you from CPAP to BiPAP ST to ASV, and expect the patient to kind of stick with us. So we do have to be a little bit careful with trying to put everyone through every single therapy. So we do have to have a bit of a pragmatic approach to our patients. And we really want to have the patient have all the options available to them and discuss them with them all at once. So we can counsel them later on and try to move them from one category to the other. So generally, I personally recommend that a patient with central sleep apnea know about all the treatment option all at once, because these patients are busy. They have heart failure sometimes, they have other chronic diseases, they have chronic pain. if they don't know that they have other options, they may just never come back. And then here's a patient who may lose on the opportunity for getting treatment and help for their condition. So, and that's what I say here is be careful with these patients. Try to provide follow-up. Don't drop the ball on them. Don't allow them to be discouraged that, oh, one thing didn't work, then there's nothing else for me here. And we all see this in our practice. We see patients who really thought that there's, the mask-based therapy didn't work, so I'm not going to be able to do anything else. So, you want to provide the patient follow-up and move them quickly from one modality to the other. The new guidelines recommend really shared decision making and disclosure to the patient that what we're looking at here is your symptoms. We're not looking at treatment that will decrease mortality. So you're talking to your heart failure patient. The patient, you can't say this treatment will improve your survival. You don't know that, but you can say it will improve your symptom burden. It will improve potentially your arrhythmia. It will improve your exercise capacity, perhaps, and this may improve other things, but we don't really have evidence right now to scare our patients and say, this is meant to impact mortality. And I wanted to just say that another thing that we wanted for people to start looking as a bit of a paradigm change is look at it as a chronic disease management. So if you did something that decreased the central events, then you treated the central apnea. If we did something that didn't do that, then the patient didn't benefit. So the reduction in the central events, we consider it as a critical outcome, because if a treatment doesn't do this, then that's not a good treatment for this specific patient. So if the patient comes back for follow-up and the residual AHI is elevated, then we need to move them to the next treatment modality. That's an option for them. And I think I will just give you here my take-home message. It's a comorbidity. Patients are dealing concurrently with severe underlying diseases, emphasis on control and optimization, consideration of chronic disease burden, and risk of losing patient to futile trials of ineffective modalities. So we really have to figure out how to transition our patient from one thing to the other without running them through every single available option. And discussion and disclosure, and quick transition from non-invasive to invasive modalities, and focus on shared decision making, partnership with the patient, and communication with your other subspecialists, especially when you're treating a heart failure patient. We really have to know the status of the underlying disease and the impact of our treatment, and we do have to see our patients regularly and look at their ventilatory and cardiovascular parameters, at their bicarb, at their quality of sleep, and is the treatment actually helping them?